DSM-5, how many people have heard of DSM anything? Everybody? How many people in here had abnormal psychology? It's a popular class. How many people are psychology majors? Okay, that's pretty good. All right, that's a pretty good number here. Okay, so y'all had DSM-5. When I went to school, I don't want y'all to be too sad, but you know, we started out with DSM-3. This was 81, 79, 80, 81. Then it was before shut and so, oh, the world has been revolutionized, and now we're up to DSM-5. It's kind of like, okay, that's like the rings around this tree. I've been through 3 to 5. Let me go back to it. You need to be familiar with it. I've got a copy of it right here. Here it is in its full glory. DSM-5 paperback version. It is all of 945 pages. Every odd thing you want to name is in this book. It's pretty good stuff. So, kind of interesting reading. Okay, it's done by the American Psychiatric Association, the APA. They put it together and they are constantly working on stuff. They made a lot of changes for this one. There's a lot of things that are changing even right now. And some of the things that were once considered disorders are no longer considered disorders. And I'll just give you one example. You know, the whole thing about gender identity is kind of like this whole new area that they're kind of they're defining and redefining. And some things were once considered mental disorders, which are no longer considered mental disorders. They're just considered another variation of people. So these things, DSM-5 moves through its understanding of the culture and keeps modifying. So that's changed, and that will probably change some more because there's quite a bit of new definitions that they're putting out. They develop their criteria for diagnosis and management. They pull all the stats together and they tell you how to make the diagnosis. Their criteria have proved reliable and they do help improve diagnosis. I would say there's a lot of diagnosis right now that's inaccurate. Just in primary care, may not spend the time to actually fix a diagnosis because it does take time in adhering to those guidelines, and a lot of times people get a diagnosis and they get labeled, and then we have to unfold it over time. Like, you're really not depressed, you're something else. You're really not schizophrenic. You're schizophrenic, or you're something different. So, but it makes a difference. It has implications for treatment. It has implications for prognosis. It has implications for how well you can function. So diagnosis is important. Of note, DSM-1 came out in 1952 after World War II, and it was mostly just to facilitate research and to collect statistics on mental disorders, and now it's actually become the diagnostic manual. So it's not just the statistical manual, it's the diagnostic manual. They've been collecting data in the United States since the 1800s, like 1830s, 1840s. They started pulling together who's in the mental institutions that were housing all these people, and it's kind of evolved all the way from there. Okay, definition of mental disorder. This is the definition from DSM-5, and it is worth knowing exactly what it says. This is DSM-5, page 20. A mental disorder is a syndrome. Okay, syndrome means a lot of elements to it. It's not just a thing. It's not a high blood pressure. It's a whole range of disability characterized by clinically significant disturbance in an individual's cognition, how they think and express themselves, emotional regulation, how they respond, appropriate or inappropriate, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. Mental disorders are usually associated with significant distress or disability in social, occupational, or other important activities. An expected or culturally approved response to a common stressor or loss, such as the death of a loved one, is not a mental disorder. People who have a loved one die aren't just depressed. It might be grief, a grief response, but sometimes people, they're depressed and will try with antidepressant. Should you? I want y'all to think about that, because there's a lot of willy-nilly sprinkled out there. I'm going to make you feel better, but it's really wrong. It creates its own problems. So there are some things that happen that in our culture are not considered mental disorders. Pay attention to the word culture. Most of you are upper middle class America, Western culture. You will see patients who are not from that background. And their response is, you'll think that's wrong. That's not the way we would do. But that's the way they do. So when you're culturally competent, you really have to know more about the way I view it. That's fine. You have to have a view. But your view of what's possible needs to expand based on culture. Y'all remember the Hamung that you read about, that first book? Didn't they get into all kinds of trouble because they thought they were acting strange and weird and they didn't do things the right way? It actually made sense for them, but it didn't make any sense at all to Western culture, and they got treated badly because of it. Okay. Socially deviant behavior, for example, political, religious, or sexual deviant behavior, and conflicts that are primarily between the individual and society are not mental disorders unless the deviance or conflict results from a dysfunction in the individual as described above. There's all kinds of chaos going on right now. Those people are not mentally ill. They just have a different view. Okay? So you have to be careful to label people, they're crazy. No, they just don't believe what you believe, but they're not crazy. Now, the minute they cross a border, then maybe you start getting into some trouble, or maybe it's criminal. Okay, multi-axial assessment. I'm not going to test you on this, but I want you to understand what it is because you will still read old records. When you look at treatment records from people that go back even into the early 2000s, 2010, 11, they were still using this axial system. And just when did y'all learn multi-axial assessment?
Yeah, because I did DSM-4 TR.
Yeah, and what they've done is they've begun to evolve that language. I'm going to tell you how it's happened. I want you to know it because you're still going to read old records built out of this way of documenting, and you have to see what did they call things so that you can deal with it now. Particularly if you get older patients, you just won't quite know how did stuff show up. It's multi-axial. It provides a systematic approach to describing a mental disorder, and we need to know it so you can read records. Okay, here's what the axes are. They have 5 axes. Axis 1, and again, don't take notes, just hear it. Okay, just stop. Stop your brains. They don't have to consume knowledge. Just understand this piece. The axis 1 is the clinical disorders and other conditions that may be a focus of clinical attention. These are the major psychiatric and behavioral syndromes addressed in DSM-5. If more than one disorder is present, the principal one or the reason for the visit is the one listed first. So if they came in because they were suicidal because of depression, that's number 1, but they could have anxiety, they could have, all kinds of other issues underneath that. Axis 2 is personality disorders and mental retardation. They were listed separately because they may coexist and complicate the diagnosis and management of Axis 1 problems. That was back in the day when everything was teased out. This is the mental part, this is the other part, and that was just the way they did it. Axis 3 is the medical conditions. High blood pressure, coronary artery disease would be listed. And conditions important to understand how to manage Axis 1 and 2. Then Axis 4, psychosocial and environmental problems. That's things that would influence management or prognosis, like from a divorced home, domestic violence in the home. These are like contextual factors would be listed. And then finally, global assessment of functioning. They used to use the global assessment of functioning scale, 0 to 100, to describe the degree of functional impairment on axis 1 and 2. Okay, kind of complicated with all these axes. Now look at this. Let that mess you up. This is that global functioning scale. Look at this jump. Just read one. Because I want to know when I read this now, how would any sane person actually objectively apply this to a person? It's impossible. Number 1, here's a score of 91 to 100, and they could say it's 95 or 93. How do you know that? Okay, person has no problems or has superior functioning in several areas or is admired and sought after by others due to positive qualities. Really? This was medicine. I can't believe it. Look down here. 21 to 30, presence of hallucinations or delusions which influence behavior or serious impairment in ability to communicate with others. Maybe they just don't like you. Or serious impairment in judgment or inability to function in almost all areas. Very subjective. Okay, so let me show you what one looks like. Here's what it would look like in a medical record. They would have Axis 1, adjustment disorder with depressed mood, alcohol abuse, cannabis abuse. Axis 2, antisocial personality. Axis 3, hypothyroidism. Axis 4, recent divorce. Axis 5, GAF, 50 on admission, 62 at discharge. And there's no way they know that. I just don't buy the scales. Okay, so they moved away from it for some reasons. DSM-5 combines the first three axes into one. Rather than separate psychiatric disorders from medical problems, it's just, you got problems. You have hypertension, diabetes, depression, anxiety, insomnia, degenerative joint disease, osteoarthritis. Okay, they did it to remove artificial distinctions among conditions. It was part of mainstreaming psychiatric diagnosis, not a diagnosis of the body. Heart can be messed up, brain can have an issue that manifests as a behavior. So they were trying to just make these all medical problems as opposed to the psych thing and then the medical thing, which created problems for patients. The fourth axis described in contributing stressors is now represented through expanded set of ICD-10 CMZ codes. So when they put down the code for the disease, they will also put down modifiers for the environment. Okay, y'all haven't had coding yet, have you? Okay, it'll come to you in the second year. But every disease has a number. Every disease, and there are multitudes of numbers. And then everything you do to a patient has a number. That's my brain's losing it. ICD codes, and you got CP, common procedure, CPT. CPT codes. I'm sorry, like if you have a follow-up visit, that's a CPT code of a certain complexity. So everything that the person has, everything that you do has a number. That's just, and you'll get to that, and you'll have to know it to practice. Fifth axis says removed because of its questionable use in practice. They use a thing now called WHODAS. I love it. Whose disability assessment schedule. Don't worry, it's not who dat, it's who does. For all you New Orleans people. Yeah. Okay. The more I think, the more confused I get. Okay, I hope I haven't messed y'all up. There's just so much kind of stuff. I want you to at least hear about axes. You don't have to remember all that stuff. You got a place to go back and look at it. Just know we've evolved how we record what's wrong with somebody. Okay, symptomatology of human behavior. Okay, you can do a psychiatric history if necessary. Same types of things here. Chief complaint, history of present illness, what it show up like, past illnesses, psychiatric, medical, and in the family. Very important for psychiatric disorders. Personal history, you can run through all the developmental stages. Adulthood, you want to know what is your work history, marital and relationship history, military history, educational, etc. You can see those. And then sexual history, any history of abuse, age of first intercourse, number of partners, gender identity, all of these things are part of assessing who a person is and where they are. Okay, any of you ever heard the term the Pre-Cox-Gefühl, the Pre-Cox-Gefühl? And I am not a German. Okay, so this comes out of German psychiatry. Have you ever heard it? Has anyone ever heard that? Okay, it's I don't know that it's used a whole bunch anymore, but I have heard it in my lifetime over time. It is a term that came by a Dutch psychiatrist used it, claimed the diagnosis of schizophrenia was sometimes bolstered by seemingly ineffable intuition, probably based on a fundamental inaccessibility to the patient. Like you're talking to somebody, but you don't feel like they're all there. You'll have that when you're talking to patients. The patients do make you feel a way. And that'll be one of the things you use to diagnose, is read your response as part of the overall assessment. But they call that the Pre-Cox-Gefühl. And is anybody here know German? Does anybody say it?
Gefühl.
Thank you. I didn't do too bad. That's German through a southern accent, so there you go. Okay, but it's diagnosis through intuition or atmospheric diagnosis, and I kind of like that. Today, psychiatric diagnosis is made through psychiatric evaluation to establish DSM-5 diagnostic criteria, but often when interviewing a patient, you may have an odd sensation of speaking with one who is not reacting normally, and then you kind of go into a more elaborate evaluation. Here's one, a sense of infectious good humor. A manic patient is one of the most fun people to talk to if they're not acting crazy. If you, honestly, you know what would pick y'all up today? If I had a manic person up here talking to you, you would immediately feel uplifted. It's like everything is possible. Man, let's go! Because people in the manic phase are energetic. I mean, you just want to let me get a hold of that life force. Let me go. And they are very infectious, and they draw a lot of people around them. You look at a lot of politicians and world leaders over time, they are manic, and they are hypomanic, and they are able to just draw folks in. Okay, don't worry, you love a politician, it's okay, they might not be diagnosed, okay, but they might. Okay, but this infectious good humor, if you feel extremely energized and cheerful during the time of the interview with the patient, maybe you should be at the top of the differential diagnosis. Of course, you got to fulfill the criteria. But I can't wait for you to actually interview a person in a manic phase. It's so notable, so unforgettable, and so exhilarating and baffling all at the same time. It's like, oh my gosh. I interviewed one manic person. This person was 23 years old, but in their delusions, they had already finished law school, medical school. They were a world-renowned designer of clothes. They were a world-renowned hairstylist, and would be, I remember the first time this person came in on my radar screen, they had been up for about 36 hours in a row, full of energy, out in the area doing hair of different inmates, you know, different patients who were in the facility. And I said, well, you know, I asked to try to be very logical, but how have you had time to do all of these things at the age of 23? I just work all the time. I just do stuff all the time. Okay. All right, where'd you go to school at? Well, I went to Harvard. Okay, well, good. It's just like, just amazing. So fun. Okay. Okay, it's worth doing. Okay, areas, there are several areas to observe when you're doing psychiatric assessment. Okay, here they are, and we're going to look at these. This is the rest of this topic for the next hour and a half. Appearance, and go back, the wrong way. Okay, you got to look at appearance, how they look, movement, disturbances of activity, or abnormal movements. Y'all have already had movement disorders. Mood and affect, delusions and hallucinations, thought and speech, and then judgment and insight. Those are the areas that you're looking at. And they'll record them just like that. That's how it's going to go down. So let's look at appearance. We don't have a clock in here, do we? Okay. Okay. It was wrong. Okay. Appearance. Here's some. I wish y'all could see this. This woman, roses are red, violets are blue. I'm schizophrenic, and so am I. I thought that was pretty good. Okay, now that's probably schizophrenia too. All right. Okay, the things you look at in appearance, you have to do everything. Look at gender, actual and apparent age, clothing, grooming and hygiene, body habitus, physical abnormalities, jewelry and cosmetics, activity, and scars. And you might actually look at gender conformity. You know, does the person, obviously male, dressing like a woman? There's a lot of, you have to look for congruency and appropriateness, however that's defined for the situation. Okay, let's look at a few appearances, and these we'll come back to different ones of these as we come to the different disorders, but this will give you somewhat of an overview of it. Schizophrenia, what do they usually look like? Appears bizarre, disheveled, and unkempt. This is the big one for me. Most schizophrenics just don't look like they're put together. Rolled out of bed, came to see you. Clothes don't match. Clothes are wrinkled. Colors and patterns mismatch. Ornaments and bits of jewelry oddly placed. May wear aluminum foil. May wear earplugs or put cotton in ears. I think it's harder to talk about jewelry and ornaments because with body piercing and the way people adorn their bodies now, things that I would have said in 1980 and early 90s were inappropriate are probably more appropriate now. So it does shift as culture shifts and what people do things to their bodies. Depression, patient appears not done. They're not really put together, no makeup, hair not really put in the right place. Shoulders sag, posture slump, head may be hung, skin may be deeply lined and lack turgor, hair may not be done, appears lifeless and dull, eyes lack any vibrancy. You look in the eyes of a depressed person, immediately you start descending. I mean, you cannot help it. You see somebody, they just take you down. It's hard to miss it. Okay, mania. Over-vitalized, I like that. Just, don't do anything. Dresses colorfully, excessive and overly gaudy jewelry, additions to hair. Okay, I'll come back. Additions to hair like extensions or beads. Another thing about mania, we'll talk about this tomorrow. They may be hypersexual. They may wear clothes that are just unbuttoned down here, showing everything, wanting it to be seen. And, oh, don't you see me? Because they're trying to arouse you, attract you as part of their disorder. Okay, histrionic personality, just as one person at a time. They're colorful but not as garish or as a manic patient. They're kind of similar in some ways when you see how they are in their full-blown phases. And then anorexia nervosa, just as from a feeding and eating disorder, they might actually have long hair, bulky sweaters, and long heavy skirts to hide how much their body is wasting away. When it becomes so apparent that they're not eating right, they try to hide that in their clothing. Okay? Okay, here's some just pictures of folks. Schizophrenia, okay, you know, kind of some odd piercing things in there. Face painted, that might be real tattooed, or it may just be put on. I would, you know, hair's really kind of pulled back, probably dirty, okay, not washed. Depression, this is a pretty good depression picture. You see this, you talk to this person, where are you going? In the hole, okay? Mania, okay, this really was, this person with mania, okay, hypersexual, red clothes, kind of cool looking. I'm going to have fun. Come play with me. Okay. Okay. If this is your sister or your wardrobe, forgive me. No. Okay. Let's look at movement. Okay, that's appearance. Let's look at movement. Okay. Here we go. There's two categories of movement we have to pay attention to: disturbances of activity and abnormal movements. So disturbances of activity is kind of broad, so let's look at them. The disturbances of activity operate in 5 areas. There might be inactivity, there might be agitation, there might be hyperactivity, there might be impulsivity, and there might be bizarre behavior. I'll do something here. Ooh, I like the green. Okay. I know, I will figure the room out. This was kind of hard to toggle between red light and advancement, and so I like this better, so I can do green. Okay, if I ever put, you see that green on your face, you are dead. Okay. How many of y'all watch Breaking Bad? You know at the very, okay, okay, without giving the plot away for those who have not seen it, because it's fantastic. The part at the end where they have the laser light pins, they have them trained on the hearts of the 2 people who deserve to be wasted. That's so good. All they have is a pin like this. Okay. Let's move on. Let's look at some of the disturbances of activity. And this is really just kind of definition. I just need you to know definitions of words. Inactivity, slowness of voluntary and involuntary movements. And some of the terms that can be used to describe inactivity are anhedonia. Ever heard that before? Anhedonia is just lack of interest. You just cannot be interested in anything. If you're an OU football fan and the Sooners are pulling up to play Texas and you just don't have any interest whatsoever, you might be depressed. Okay. Anergia, that's lack of energy. That's no way to describe it. Psychomotor retardation, slowed speech, decreased movement, impaired cognitive function. You see that in depression, psychomotor retardation. Oppressive fatigue, sense of painful inhibition of all processes. Just can't do anything, can't get out of work. I want to answer that question. Just come down. Okay, ambivalence. There are people who get paralyzed by ambivalence. They cannot choose one thing or the other. For example, inability to choose between a spoon or a fork causing a patient not to eat at all. That can happen. You just cannot make up your mind. Can't decide, so you do nothing. Annihilation of the will, sounds pretty terrible. No capacity to conceive of a purpose and follow it, cannot move towards purposeful activity. For example, spending hours gathering bits of dust or lying in bed, going nowhere. Okay, another disturbance of activity is agitation. Physical restlessness with increased inner tension and level of arousal. They will tell you, can't sit still, just have to move. It's in here, and it shows up out here, but it's inside. They just feel that. Terms used to describe psychomotor agitation is one. Movements that are caused by psychiatric condition like anxiety rather than by external forces, caffeine or cocaine. If you're taking caffeine or cocaine, you're hyped up on a drug. If you have a psychiatric sort of like manic phase and you're just going on, that's psychomotor agitation. It's coming from brain dysfunction that shows up in movement. You take a drug and you're bouncing around, that's an outside agent influencing you. It may look the same, but it's a different definition. Excited catatonia. Hyperactivity seems senseless and bizarre with no purpose. For example, touching all the doorknobs, jumping around, marching frantically, can turn violent. Manic excitation, purposeful agitation with an extreme abundance of energy, but activities may not be completed. Also can see hyperactivity and hypersexuality in manic excitation. Okay, do some more. Okay, hyperactivity, increased levels of physical energy. Okay, just by definition, so that's it. Impulsivity, we'll look at it for mania and schizophrenia. In mania, impulsivity, one after another, the impulses override whatever steadying forces still exist in the patient. No interference is tolerated, no obstacle is too great. If anyone tries to block the patient's impulse, they may encounter abuse. Manic people in the manic phase, their impulsivity is wildly notorious. It tends to be hypersexual. They'll have sex with anybody that when they're on the prowl. They like to gamble. They'll spend money like crazy. They'll blow a bank account, and they just can't stop. It's part of their disease. Schizophrenia may have impulsivity without warning or provocation. A catatonic patient may leap up and smash furniture and then go into a state of catatonic stupor. So you just be sitting there, looks good, okay, okay, bam! Okay, all right. Then kind of stand back. Okay. Other impulsivity seen with different diagnoses, alcoholism and drug abuse, irritability and any harbored fierce resentments can easily overwhelm whatever restraining good judgment left. Alcohol and lots of drugs, they disinhibit. Have y'all heard that word before? It's just a disinhibition. So if you don't like somebody, I mean, there's a lot of people that we don't really care for. We may think all kinds of things. Under our own power, we don't have to show that. Under alcohol, you may show it. And you may say something bad about somebody that you really had wanted to say for a long time, but you knew you couldn't say it because you'd get a punishment in this world. Other drugs will pull that off and you don't really care. Then you'll apologize, I'm sorry, but I think the truth just landed. Okay, such as it is. Borderline personalities, patients often lack restraint and good judgment, leading to self-destructive impulses. They can do crime, they can do all kinds of things. Dementia or mental retardation, these patients never fully acquire self-restraint. They're more like 2-year-olds, but there's an impulsivity that goes along with that mental lack of mental development. And then attention deficit hyperactivity disorder may be marked by impulsivity. For example, a child blurts out whatever comes to mind or acts on whatever impulse arises. So these are just examples of terminology that we use for impulse. And then finally, bizarre behavior. Bizarre or grossly disorganized behavior should always make you think about schizophrenia. When people do things that just don't make sense. An example, I've seen this before. A person goes to the bathroom, they defecate, and they smear their feces on the wall. Now, what does that have to do with anything? When I was at the VA, a patient came to the front desk. This person wasn't schizophrenia, but it was inappropriate behavior. Came to the front desk, wanted to be seen, was in the emergency room, wasn't going anywhere because it wasn't an emergency, and so he had to wait and wait and wait. So he finally got to the front desk and said, I want to be seen, or I'm going to do something strange out here. And they said, you will sit down and you will wait your turn. he dropped his pants and defecated on the floor in front of them, and then he probably got carted out by police. Okay, now that person probably had some issues, okay? But that's bizarre behavior. All right, here's some other ones. Patient paints windows black so others can't spy on him. That's the paranoia of schizophrenia. Patient marches in one place for no apparent reason. Patient papers a room with tinfoil or turns furniture upside down. You know, they make, schizophrenics like to put aluminum foil and stuff because it's like receptors and antennas for signals coming from the other worlds. Don't y'all all see it? So this planet, the moon, that apartment, they're sending radio signals to me and I can receive it this way. Okay, pretty weird. Okay. Let's go here. Okay. Abnormal movements. We may move through these fairly quick because I think you've had these by definition. So let me just ask you, you tell me, and then we'll just go on. Okay. So tics, chorea, and tremors. Have y'all been over all of those? Okay. Akathisia. Did y'all have that? We'll look at that. Tardive dyskinesia. A little bit. Okay. Dystonia. Y'all had dystonias? Okay. Compulsions, probably not because that's a behavioral manifestation. Catatonic symptoms, and had that. Okay, let's look at a few of these. Okay, tics, I'm just going to move through these tics. Okay, y'all had the definition for tic. That's a clip, it's kind of interesting, but I think y'all already seen clips of this. Have y'all seen tics in action? Okay. Coprolalia, okay, vocal tic, patient utters obscenities, that's just cursing out. Y'all already did that. Y'all did Tourette's. Okay. Chorea, did y'all do Huntington's disease? Did y'all do St. Vitus's dance, all this stuff? All right. So Dan's like, there's a picture if y'all want to clip on that. And then here's causes. You've seen that. But, okay. Tremors, you had postural and rest tremors. Okay, we're not going to waste time doing it again. All right. Intention tremors, did y'all do that? Did y'all do floppy tremors, asterixis? Okay. Okay, there's some. What disease besides these two do you see asterixis in? There's a common disease. Y'all had Wilson's and y'all had, did y'all have autism? Okay, so that's a little bit new. There's another case where you see asterixis. Did they talk about when you have cirrhosis far advanced with ammonia buildup? You can see asterixis with that too. That's like an alcoholic liver flap. It's out there. But anyway, you've got intention tremor, and you know what that's from. Cerebellar lesions. Is that one we test today? Yes, it was. Okay, let's move on. Akathisia. Now, this is the new term. This is the new term, akathisia. State of it's a state of inner sense of the need to be in constant movement, motor restlessness. Akathisia is when a person can't sit still and they tell you they feel like they can't, they will tell you they feel like they can't sit still. So it originates internally and it shows up as movements, but they will tell you how restless they feel inside. That actually, akathisia can be caused by certain drugs that are used to treat schizophrenia, and it can be pretty notable. So you need to always remember that, because if somebody's on those drugs and they are being accused of not sitting still and can't focus, then it could actually be an adverse effect of the drug. Tardive dyskinesia, y'all did have that? Okay. Did y'all talked about tardive? Did y'all talk about drug-induced versions? Okay. Okay, good. And there's some here with the lump, the tongue protrusion, lip smacking, puckering, all that stuff. Frightful. Dystonia, did y'all have that? Y'all did? Did y'all have the words like I've heard it pronounced torticollis and torticollis. You ever heard that? Torticollis? Torticollis. Okay, so I gave y'all a new version. Okay. Laryngospasm. Did y'all? So y'all did look at this, and did you see a picture of that? Okay. I actually had torticollis. I had dystonia one time. The doctor will test me on that. She did. We're sitting in the house, and I had compazine suppository because I had this terrible GI virus, so I couldn't keep anything down. I was throwing up. And I mean, within 30 minutes to an hour of having taken that compazine, which is a phenothiazine type antipsychotic, but also has antiemetic properties, I started to feel kind of weird, and I felt like my ribs started to feel kind of like they tightened and then they relaxed, but it wasn't bad. And I thought, what is that? And then my neck started to kind of do this, and just a little bit, but then it got more pronounced. I could not get a deep breath. It would just tighten up, and I was trying to, and I couldn't do that, and it would just involuntarily just all tighten up and just restrict your diaphragm down. It's like, you feel like you're getting choked. So it's very panicky. I said, go to the ER. I know what this is, just go. So we drove up to Evelyn. I said, I need Benadryl, I need diphenhydramine IV. And so as soon as I could stick this, I'm sitting here arching over and stuff. And they put in the IV, and as soon as the fluid, as soon as it went out, it went away immediately. Magic. 1 second. It was that fast. And I thought, oh gosh, it's scary. So I don't want, I haven't had it yet. I don't need to get. I got dystonia now.
What is there another name for that?
Compazine.
No, I think she was telling us under a different. It was like a side.
The pyramidal.
Extrapyramidal.
Yes.
Yeah, they're all the dystonias. There's a whole group of things called there's EPS, extrapyramidal syndrome, and it can show up a lot of different ways. Tardive dyskinesia, dystonias. These are all part of an extrapyramidal picture that can happen with drugs. Okay. Compulsions. Now this one you haven't seen, but this is kind of a behavioral movement. Repetitive behaviors or rituals a person feels driven to perform in response to an obsession or intrinsic rule, something they made up in their brain. Okay. Aimed at preventing anxiety or reducing distress about an obsession or preventing some dreaded event or situation. It's not connected in a realistic way to reducing an outcome. For example, washing hands excessively, cleaning, rechecking locked doors, going back and looking at something, looking at it, trying to prevent a house fire, like you lit a candle but you don't want to put it out. Everybody has some of these, okay? Most people have some of these, but it's when they are uncontrollable, repetitive, ongoing, and create this major dysfunction. Y'all all have some. Don't have things you have to do. And so it's just kind of like before tests, there's certain things you do. When you're I can't study in a dirty house. If the house is messed up, I cannot study. I'm sorry. If I'm in my room and I'm studying, that place better be in order. Because if it's disordered and chaotic, I cannot, I'll just clean up. And now Dr. Latessa knows this. I gotta clean my room up. It's on my nerves. I gotta have it fixed. Just leave me alone. I'm not crazy. Just let me hear it. It's like, it's like, don't touch anything. Don't touch anything. Okay. How about having disease? Okay. But they're unwanted. They're performed consciously and they're ritualistic. Okay. Take a break. It's 3:02. We'll come back in. Give yourself 10 more minutes, and we'll come back in.